Welcome, everyone. Okay, I'm going to get started. I'm going to get started. I am Miranda Vargas. I am the Senior Health Strategy Specialist here at Building Changes. I joined BC in an official capacity in January of this year, and I'm very excited to be a part of the practice innovation team where we are doing all sorts of fun work around housing, education, and now health, and which is why I'm here today. So just so you all know you're in the right place, we are going to be talking about the landscape, the Washington landscape of health and housing services integration. So if you're in the wrong class, now would be the time to sign off. But again, as people file in, feel free to introduce yourself in the chat. And here we go. Oops. So just to give you a little background about Building Changes, if you don't know who we are, we drive and promote change in the systems that impact people experiencing homelessness. And in particular, we focus on youth and young adults as well as families. And as I just mentioned, we focus our work in the areas of housing crisis, education, and health. In housing, we advance equitable strategies to support people experiencing homelessness and housing instability. In education, we lead a statewide effort to improve academic and housing outcomes for students experiencing homelessness. And in health, which is a bit of a newer branch in more recent times, we strive to improve equitable healthcare access to support health and housing stability for people experiencing homelessness. So if you have any questions about those things or are curious about those things, feel free to reach out after this webinar, and I'd be happy to, connect you and chat with you. So what to expect in this next hour and 15 minutes that we have together. So I'm going to talk a little bit about why we care about health and housing integration, why this is something that BC has chosen to focus on and, has been research that we have been doing over the past about year. Then I'll talk a little bit about the context of how health and homelessness are intermingled. Then I'll share with you about the statewide research that we conducted, just the overview and learnings about that, as well as the recommendations that came out of that. And then we'll hear from a real life, real person doing the real work of health and housing integration. We'll hear from Alyson Moon of Mary's Place a little bit later. And then there will be time for questions. I just want to say, just due to the time that we have, I want to make sure that I'm able to get through all the material. So if you have content questions, totally feel free to put that in the chat. But also, I'm probably not going to answer those types of questions until the end. So if you have content area questions, please, try to bring that up at the end. If you have questions related to like clarification or not understanding something or of that nature, please let me know immediately. I want to make sure that everyone stays on the same page and that we, understand all the information. So those questions, of course, allowed at any point in time. So I appreciate that. Thank you. So just as a little icebreaker, we are going to use Mentimeter. For those who don't know what that is, it's just an online tool to kind of poll people or gather information, questions, things like that. So since there's so many of us, I thought a nice little icebreaker might be doing just a little intro question. So you can either scan this QR code on your phone. We'll put this link in the chat as well. You can open up this link and type in the code and answer the question of, in a word, what comes to mind when you think health and housing integration? broken barriers, security, low income, justice for BIPOC patients. Amazing. So as we can see, we're all coming in with kind of ideas and thoughts about housing and health integration. And I don't expect those to necessarily change in this hour together. But I just wanted to honor where people are coming in with that and appreciate everyone's participation in this little word cloud. All right. And feel free to keep adding to that if you like, if you're so inspired. So why health and housing? So we know that there are many unique barriers that people in housing crisis face when they are trying to access healthcare, among with, accessing many other services. One of them in particular for youth and young adults is discoordination between institutions. So we know that when adults as well and youth exit systems of care like foster care, the juvenile system, the behavioral health treatment system, they're often released without proper coordination of services. So for example, 1 in 4 youth that come out of foster care and 1 out of 3 exiting the juvenile system will fall into homelessness. And therefore they've lost access to whatever networks they had before, whatever care they might have been receiving prior to that. Therefore, health and healthcare becomes a low priority. Poverty, gentrification, and systemic racism are obviously barriers. This is acutely felt by Black, Indigenous, and people of color, youth, young adults, and families. We know that displacement out of known areas or places where they might have grown up or live takes people out of those community spaces where they might have trusted providers. They might know people that can provide care that they need. And when you're removed from those situations due to a number of reasons, poverty, gentrification, racism, you lose that access. In particular, BIPOC folks have a long history of mistrust of the medical system, and that is due to being mistreated by the medical system and medical professionals, and that continues to this day. For instance, we know that studies have shown that medical providers often minimize Black women's pain in particular, which can lead to maternal and infant deaths or complications. And we know that Black maternal death is 3 times higher than the maternal death of white women. And a lack of housing options, short and simple. Once people enter the homeless system or lose their housing in some kind of way, there is not enough housing to catch them, whether that's shelter, transitional, permanent supportive. Youth and young adult groups in particular are affected by this, especially if they are pregnant. For example, there's only 1 housing program left in the state that specifically works with teens who are pregnant. So there's just, so when you have that kind of lack of access and that lack of a safety net, the connections you have to other services like healthcare become reduced even more. So what are the positives? Like, why do we want to invest and think about investing in health and housing integration? So there's information that shows that when you integrate health and housing services, it increases the number of visits that a patient will have, simply by nature of the health, whatever, being, whether it's a clinic or mobile health, whatever it is, in the space where they are living and coming and going every day, they're able to literally just take away that barrier of needing transportation or missing an appointment or things like that. So it increases the number of visits. It also helps in shifting clinicians' perspectives. So as I mentioned, the providers are human. They're not exempt from having bias or other things like that. So having them work specifically in areas where they are interacting with people in housing crisis or who have complex lives, this can kind of help shift providers' perspectives around like who their patients are and what they need, as well as just the ways that they can provide care to folks that is going to meet them where they're at, and that they'll meet their health goals, whatever they're working on. And a part of this all wraps up into improving the quality of care. So this includes both patient and provider satisfaction. So on both sides of the coin, folks feel like their care is taken more seriously, like they have more options, and their healthcare is being taken care of. And on the provider side, feeling like they can do more, they can reach people, and so therefore the satisfaction is greater on both ends. And the final example I provide is that health and housing integration creates a healthcare home. Literally, this means a place where someone can go for their primary care, and they have people there who they know can help them. They can go there for a number of health reasons, and from there they can shoot out to specialists if they need them or other services. But it really creates a place where people feel like they belong, where they can go to and rely on for care, and they know that they will be met with what they need. And of course, this is all, these are just some examples of ways that A, there are barriers, and B, there are benefits. Of course, this is not an exhaustive list, but these are just some of the ways that health and housing integration is something that we want to focus on. So as I mentioned at the beginning, Building Changes, we really spend our focus on working to support youth and young adults and families. So youth and young adults generally spans from the ages of 12 to 26. And unaccompanied, for those who might not know, means that they are either minors or young adults who don't have a parent that they are with. They're like on their own, they're managing their lives on their own, they're looking for housing on their own, things like that. So there's not that familial relationship going on. In terms of how health and homelessness are intermingled for youth and young adults, we know that over 50% of YYA experiencing homelessness have a drug or alcohol use disorder, as well as overrepresentation of mood, psychotic, and trauma-related disorders. Suicide is the leading cause of death of youth and young adults experiencing homelessness. A study reported that 48% of women and girls and 27% of men and boys have attempted. And then there's disproportionate anxiety, depression, self-harm, PTSD, conduct disorders, HIV and AIDS, and early death among youth and young adults who are in housing crisis. And it's always important to remember that when we are talking about youth and young adults who are homeless, we are talking about a group that is also disproportionately BIPOC and queer. So just as an example, in 2019, Black youth made up 24% of the homeless population in Washington state, but they're only 6% of the total youth population. And likewise, 40% of homeless youth identified as LGBTQ+, but represented 3 to 5% of the general public. So when we're talking about these health outcomes that are disproportionate in homeless communities, we're also talking about largely queer and youth of color in that space. Among families, which we define as an adult caring for at least one child or expecting, children experience greater behavioral behavioral and mental health issues, adolescent depression, substance use disorders, and teenage pregnancy. Infants are at greater risk of respiratory infections, fever, allergies, injury, and developmental disorders. And women and people with uteruses have elevated risks of reproductive health issues, including STIs and other infections, earlier unplanned pregnancies, miscarriages, forced births, sterilization, and abortion. And just as a note, abortion is on this list not because it itself is an issue, but because it refers to unwanted abortions or the necessity of having one because of birth complications with the fetus or with the mother that might impinge on her life. And again, among this group, we are talking about disproportionate numbers of BIPOC people. And along that note, BIPOC parents reportedly have higher rates of depression and mental health issues as well, and are much less likely to seek treatment than white folks. And that's in part due to the barriers that I mentioned earlier: poverty, gentrification, racism, and again, I also mentioned this, but we know that for Black mothers and their babies, infant and maternal deaths are 3 times higher among them than white folks. So again, when we're thinking about these populations, just always with that lens of who is being disproportionately affected. And among these populations, it is BIPOC folks and queer folks. So over the past year, from about August of last year to March of this year, I, along with some others at BC, did some statewide research around, again, what is happening at the intersection of health and housing for organizations that are working with youth and for orgs that are working with families. And we really wanted to just better understand, again, just what is going on around the state, and to be able to just have that kind of baseline information and learn from it. So what we did, this was a multi-part research project. So the first was doing a landscape scan, which involved a literature review and interviews with key informant housing and health service providers. And then we did a series of listening sessions. So we did 3 with providers and 2 with clients of said providers. And in this case, we were only able to speak with youth and young adults, not only, but like we weren't able to make it happen to talk to, parents and guardians and families. So we had 3, as I said, we had 3 provider group listening sessions and 2 with youth. So here were all our key informants. I did 33 total interviews, and Building Changes already has relationships in many counties across the state. And so we really wanted to be intentional in connecting with folks that we have relationships with already. So we focused on King, Pierce, Snohomish, Spokane, and Yakima counties. And then we had little sprinkles in there from Walla Walla and Okanagan County, just to really get us a broader scope across different types of areas. So we've got like our urban areas, King and Pierce, and then we've got, rural and super rural, I don't know what the official terms are, of, Snohomish, Spokane, Yakima, and Okanagan and Walla Walla counties. So among these 33 people, 9 organizations have a health-based component, 22 have housing programs, and 14 offered social services, were administration focused, or were funders. And these numbers don't add up to 33 because, several of these organizations offer multiple things. And then for our listening sessions, for our provider group, We tried to break them up into counties. So we had King, Snohomish, and Pierce in one group, and then we had Spokane spread over a couple of groups. And we did talk to one organization that works with families, but the majority were with youth and young adult, people who work with youth and young adults. And then our client groups were from New Horizons, which is a youth shelter in Belltown, and Urban League, which again has a youth shelter in the Central District. So what did we learn? What did we learn from these folks? So in talking with organizations, I identified this group of models of integration. So these are just some of the ways that the majority of organizations are going about integrating health and housing. And I'll go over these more in depth in a moment. But as you can see, the majority of providers, 17, had some kind of embedded health staff in their housing units or programs, what have you, with mobile healthcare being the next highest at 12. And then as we go down the list, we've got 4 providers each for having some sort of embedded care navigation, specifically related to health or health insurance enrollment. In-house respite care, whether that's postpartum or post a hospital stay for a child, for instance. Many had, if not all, had referral relationships. And by that, I mean like official MOU type style relationships with with like health related organizations or housing, if they were a health org. And then some to each provided logistical support and had home-based visits as well. So what do these all mean? So embedded healthcare staff essentially means that, let's take New Horizons, for example, they have a dedicated space in their shelter where once a week, a doctor and a behavioral health person come and they have visits with their residents. That's one model of doing it. But essentially what this means is there is some kind of like dedicated space or time where healthcare, whether it's medical, mental health, behavioral health, they come to that place of, that's their place of work, is like in the housing program. The second, the mobile health care, kind of self-explanatory, but meaning that a housing program has a partnership with a health organization that has some type of mobile situation, whether it be a van or just a team that comes around. So a number of times a week or a month, you know, a dental van might come around and do simple checks. There might be vaccine vans or vans that come and do vaccines for kids before they start school. There might be like specified health services that are mobilized, such as doing mammograms or you know, doing screenings for certain types of mental health things. So this can look in a lot of different ways, but generally comes down to, is the health team mobilized and they are, you know, traveling around to various sites doing that work. Next, we have embedded navigation in housing. So this means essentially the same thing as having embedded healthcare staff. Like there's a dedicated space staff person, you know, they're getting a paid wage and things like that. But they're not a healthcare provider. They are doing health navigation. So they're helping connect people to providers in their community and or helping them enroll in health insurance, making sure they have all their, you know, health benefits set up and are understanding them, and kind of just helping them navigate the system of healthcare to get their needs met. In-house respite care refers to again, a dedicated space in the housing program where, say, mothers who have just given birth can spend some time with their newborns to rest, recoup, bond with their child, you know, figure out breastfeeding if that's what they choose to do. And in a safe and like secure place that isn't where they don't have to worry about, you know, where they're going to sleep that night, or, you know, caring for their child on the, you know, in a car or in their friend's house or something. And there's also, this could also be a place for, like, if a child has a surgery or chronic illness and they're coming out of a hospital stay without a stable place to be to recover, there's a space for them there as well. And referral relationships means there's some kind of official, like, memorandum of understanding relationship between health and housing organizations. So this might meet, and not in the way of like having an embedded healthcare staff or a mobile health team. It's more like an official way of being like, okay, this is my housing program, these are our residents, and we are going to send them to you, health agency, in X capacity, in X official way, in Y official way, and vice versa. So there's kind of that just communal relationship there, and warm handoffs that are happening between health and housing clients. Logistical support means that the housing program is specifically providing like transportation to a clinic. For example, youth care has a van that they load up their residents in who are staying there that night, and will take them over to the Neighbor Care Health, for the Neighbor Care 45th Street Youth Clinic in the evening, so that the youth and young adults don't have to worry about, you know, getting on the bus. They don't have to deal with all of that. They can just get on this van and get carted over there and then carted back. Or providing bus passes, providing flex funding, things like that to help people get what they need to like make sure that they can access their healthcare. And then finally, we have home-based visits. There are a couple orgs who do that, meaning this might be for folks who are more in housing crisis. They have a place to live, they're in a place, but they might be teetering on the edge of eviction or have some sort of unstable housing situation. And those nurses, for example, will like go into their space and meet with them there. And if folks are without a home or a place to stay, they will meet them wherever they are at and need to be to safely meet with whoever their provider is. So the recommendations that came out of the interviews and listening sessions are several. And these are not the only ones, but these are the ones that were mentioned across the board among providers, the youth and young adults that we were able to have listening sessions with, and that were mentioned across geography. So whether it was urban or rural folks, these were the most ubiquitous messages that came through. So the first recommendation is to improve health provider skill sets. So as alluded to, you know, providers have their own biases, they have their own belief systems and values, and wrapped up in that is racism and transphobia. And generally speaking, there's not a great understanding of what homelessness trauma is, what it can look like, what it can look like in youth, what it can look like in children and adults. There's not that. So when folks go in to get their care, they might be met with, at the best, like a misunderstanding, and at the worst, full on a minimization or dismissal, or just being like people being mean to them or rude to them. Either way, their needs are not being met and they're not getting the care that they deserve and need. So really So recommending really doing some work to improve health providers' skill sets around working with folks who are experiencing housing crisis, because it is a skill set. You know, there are harm reduction and trauma-informed care philosophies and trainings and things like that that can help do that for providers. The second is meeting holistic needs. So particularly around youth and young adults, I heard this, where, you know, we can do the work of getting an 18-year-old into an apartment, but if they have not had the stability through their life to learn certain skills, like life skills, like how to keep your space clean, how to budget, how to pay your bills, how to, you know, navigate landlords and things like that, you know, that can result in that 18-year-old ultimately losing their housing yet again and going back through the cycle of the homeless system. So along with housing and health services, really making sure that life skills are mixed in there, and not that that has to be separate from health either. Like they're not mutually exclusive. So really taking that time to understand what your clients need and what is going to help them sustain housing. And similarly, keeping families together. Something I heard a lot was, you know, shelters, housing programs, they might break up partners, they might only take a certain number of children. So parents have to, you know, figure out who's staying with them, who's going to stay with their auntie, et cetera, et cetera. And that can also just create more dynamics of that separation involves. And so being able to like help them navigate either staying together like from jump, or helping like navigate those dynamics and like how to assist the family members who might not be in the housing program. Next, we have alignment across systems. So we all know that definitions of homelessness, eligibility criteria, things like that may be different across sectors, across institutions or organizations, and that can really create, again, discoordination upon release. So a release of a program, for example. So, and this can also apply to funding as well. So like what type of programming is eligible for what type of funding. So really working to try to align across those systems to better help the people that we are accountable to. Similar vein, creating flexible and targeted funding. So I heard a lot from especially rural community providers that, you know, they're not eligible for a lot of the health funding that is presented. That might be due to the raw numbers of people who are experiencing homelessness are lower than urban areas, but doesn't acknowledge that those people like still need housing, they still need healthcare, and rural communities might be very well poised to receive funding to support those people. And likewise, having unrestricted funds is essential, especially when, you know, we're talking about a problem that, you know, I think at the baseline, like at a basic level, like every person who's experiencing housing crisis in every part of the state, like needs food, needs housing, needs clothing and healthcare. But how that looks and how that is addressed in that particular community might be different. And so being able to have funding that doesn't pinhole people into a specific intervention or avenue and allows them to be creative and address the needs of their specific community. Next, I heard was building community relationships is key. So this could mean planning health and housing integration early. So, you know, you're getting a contract for a new housing program or a new clinic, maybe, you know, reaching out to your community members and seeing who might I be able to work with to really integrate this early on. So we have this set in place. Maybe we have a dedicated space for a clinic or what have you in our housing program. And also putting collaboration over competition. You know, this is just classic nonprofit stuff, I think, where, or governmental, where, you know, funding is limited or is seen to be limited. And we sometimes get caught up in that, I think, and may lose some creativity around how we might be able to collaborate and like use funds together, especially when we're talking about health and housing, which have generally have very different like funding streams and places that funding is coming from, and is very like separated and divided. So finding ways to have that collaboration. And then finally, but not least in importance, is centering the voices of clients. So nothing about us without us. So folks of color, queer folks, people who are living in housing crisis, you know, making sure that they have a place at the table for planning, for evaluating things, and really also leaving space for that client involvement to allow you to pivot if changes come up. For example, I spoke with one organization that they were starting a teen housing program, and they had this like idea in their head of what it was going to be. They started doing it, and then they got all this feedback from their clients, and it was like not matching what they meant it to. So they fully pivoted their model to be something different. And admittedly, they were like, it was really hard, it sucked, but we did it, and the result was better for it, and our clients were better served. So really allowing kind of that maneuverability and space for that kind of pivoting. With that, I would like to welcome Alyson Moon of Mary's Place. She is the Director of Community Impact and has been at Mary's Place for about 11 years, which is pretty amazing. So I would love to welcome her in sharing about the health and housing integration work that Mary's Place is currently doing.
Yeah.
And would it be helpful if I stop sharing my screen?
I don't have a PowerPoint, so it's up to you.
Okay. We'll just leave it for now.
Okay, sounds good. Thanks, Miranda. So as Miranda said, my name's Alyson. My pronouns are she, her, and I serve as the Director of Community Impact at Mary's Place. And like you may have just heard, I decided to do something really radical and not have a PowerPoint presentation. So hopefully what I share verbally will be interesting enough to hold your attention. So just some background information about Mary's Place. We're a homeless service organization in King County with the mission to ensure that no child sleeps outside by centering equity and opportunity for women and families. We offer a comprehensive set of services to really meet people where they are. Mary's Place started as a drop-in day center for single adult women experiencing homelessness, which is a program that we still operate, and has grown to focus on families with children. We're the largest provider of family shelter in this community, offering 720 beds each night across 5 different shelter sites that are spread over the county. For families in our shelters, we offer wraparound supports, including meeting basic needs, housing navigation, health services, youth services, and then a variety of other supports that are provided through partner organizations. We also have a mobile outreach team that works with unsheltered families and families fleeing domestic violence, going to where they are to really support transitions directly from homelessness to housing. We also offer a homelessness prevention program, which is some of the newest work we have underway, and that provides rental support to families with a history of homelessness to help them remain housed. But the topic at hand is around the integration of health and housing work. So let's talk about Mary's Place path to integrate health services into our housing related work. When our day center first started, there were women that were coming in with some major medical and physical issues, but really very limited connections outside of going to the emergency room. And so we applied for a grant to bring on a parish nurse and got a nurse 1 day a week. She actually worked out of a little closet that we turned into an office at the time. And she was really busy because the need for health services was really high amongst the women that dropped in at our day center. We reached out for additional support so that the nurse would be able to add another day or two. And she also started working to build relationships and connections that would allow for women to then reach out to the resources they needed in the community. We were eventually able to get a nurse funded for 4 days a week and bring additional health services in through the connections that she was making. And we also early on established relationship with Bastyr and then expanded that to other providers over time to really expand our referral pathways and the on-site services that we were able to offer that connected people with a variety of forms of healthcare. So that was really where we started, which again was at our day center. So as we've grown our services for families, we've also grown our health supports for families with children. Families are in shelter, hopefully for a short time. So really the goal of our health services is to get people connected to external providers and health supports in the community that they will continue to use even after their stay at Mary's Place has ended. So in 2018, we had only 3 employees on our health services team. And today I can tell you we have a team of 13. We have 7 clinical staff and 6 behavioral health staff, which is a service that we added back in 2020. And across these teams, our staff includes care coordinators, RNs, ARNPs, doctors, behavioral health specialists, and an administrative director. So I want to highlight just a couple of specific health-related programs that we feel are really innovative and unique. And the first one I'll share about is our Popsicle Place program. This program is designed to serve families who have children that have complex medical conditions or needs. Medical needs of children have an impact on the whole family and can really increase barriers to housing and the length of stay for families in shelter. So what we see is that when a child in a family has a significant medical need, the rest of the family's health needs tend to fall on the back burner. So our Popsicle Place program, while focusing on the needs of the child that has medical complexity, also works with the full family to ensure that all the family health needs are met. There's a really strong care coordination component to our Popsicle Place work, really ensuring that the family can get to the medical appointments they need to go to, have conversations with their care provider, receive the medication they need, and then make sure that the shelter stay that we're providing accommodates their needs and keeps their child safe and healthy. We also have Popsicle Place work embedded in our outreach team. So we have a number of coordinators who work with families while they're still in the hospital with the goal of preventing discharges to homelessness. And that team also provides training and education to hospital staff on housing insecurity and navigation of the homeless service system. Miranda, you talked about doing this in partnership and collaboration. So I want to call out one particular partnership that our outreach Popsicle Place team has, and that's with the Substance Using Pregnant People program through Swedish. We've really seen amazing success there. Our Mary's Place staff actually goes to that program, which is an inpatient treatment program for pregnant people experiencing substance use. And we help navigate the discharge from that program to one of our shelters to really ensure continued substance use recovery and healthy pregnancy, as opposed to someone being discharged back to the streets where the likelihood of success with recovery is significantly decreased. So that's our Popsicle Place program. A second program I'd like to highlight is our Baby's Best Start program. I don't know if y'all know, but we actually every year have many babies that are born in shelter. Our Baby's Best Start program provides really intensive care coordination to any pregnant person and to families who have a baby under 1 year of age. The program has a really strong partnership with public health agencies that support pregnant people and new babies, like WIC, for example. We're able to get families connected to these services they need through direct pathways where we're able to engage in ongoing communication and collaboration for care. We see many pregnant people come to us who have had little to no prenatal care. So we work really hard to make sure that people are able to get connected to prenatal care and have a healthy delivery. And then supplies can also be a real struggle for families. I don't know if anyone has ever had a C-section and then tried to carry a baby. But for our moms, this happens a lot. Strollers are really hard to come by, so this is their reality. So our Baby's Best Start program is really able to help new parents get the supplies they need, like a stroller. And then finally, I just want to end by talking a little bit about our behavioral health services. Health really is holistic, not just physical. So back in 2020, we started to grow our behavioral health team. The addition of behavioral health services has really been incredible. We started with just a single staff and then have grown that team over time due to the success of having behavioral health supports available in-house. Our behavioral health team is really all about building bridges to get people connected to community providers. There's a lot of families that we serve that are assisted by both our clinical and behavioral health teams. So there's a lot of coordination between these teams to support holistic needs. And our behavioral health team also provides support and training to our staff so that our staff are then better equipped to support our guests with significant behavioral health challenges. Given the strong intersection of domestic violence and intimate partner violence with homelessness, our behavioral health team also provides support and connection for survivors. In general, there are many challenges and competing demands that families experiencing homelessness face. And if they can't easily access healthcare or an appointment, they often won't go because other needs are going to take precedence in that moment. So we really have to make it easy for families to access healthcare, which is what we've been trying to do through the programs that I've described. Supporting people to have their health needs met really frees up some space and time for them to really focus on housing. Once they're safe and healthy, they can then focus on the next thing to move their family forward to stability. So I think that covers it for now. And also happy to put my information in chat if anybody has curiosities you want to follow up about. And also happy to take any questions when we get to our Q&A time.
Alyson, thank you so much for sharing all of that. Love to hear about your work and greatly appreciate you being here and sharing about it. So at this moment, I would love to spend about 5-10 minutes on questions. So if you guys have questions for Alyson, if you have them for me or anyone else in the room, please go ahead and raise your hand or put it in the chat, and would love to, answer any questions you have right now.
Hi, this is Catherine. I have a question, and it might be for you, Miranda, or it might be for Alyson. What did it take to establish those interconnected services? Like, what is the ramp-up period? How do people do that?
Yeah, I can talk about, I don't know, Miranda, if there were things that you heard in your research from other providers, happy to share kind of about what that looks like for Mary's Place. So I think part of it has come from us, like working with our guests and understanding what are the needs that are unmet, where they're needing additional support. And then we've started essentially like all of our health services programs through a small grant to fund a single position. Once we're able to fund that single position, we can then demonstrate the success of that work and then better make the case for additional funding for the work. We're in the process right now of like exploring Medicaid reimbursement for services, which is like a big complicated thing, but are also looking at like, is there potential there? I think in regards to just like building partnerships in the community, it's really just been a lot about relationship building. One thing we found with like hospitals and clinics is that, I don't know, my impression of the homeless service system is that it's very complicated. I've been in this work for over a decade, and there are still things about navigating our homeless and housing services that I don't understand myself. And so we noticed that a lot of providers in in medical settings, for example, didn't have a clear understanding of how the housing and homeless service system works, because of course they don't. It's complicated. And so we really found that we were able to offer, providing support and education to them so that they were better able to understand how to get their patients connected. So there was like some mutual benefit in something that we were able to offer in providing support to the patients that they were seeing. So those are the things I think I would highlight, and kind of like how we've ramped up and worked on building partnership and relationship.
Thank you. That's helpful.
I think I saw a question in the chat. What efforts is the state/government doing to support health and housing integration? That's an excellent question. I think that, well, let's see. In my research, I did talk to a few county like departments of health services and housing services. I think that they're, on more local levels, county or municipality levels, there are maneuverability with like relationship buildings, and like having creativity around how to integrate is a little greater. I am not thinking specifically of an example right now, but I can go back and look and let you know. I think on a state or higher level, I just think there's a lot of opportunity for bridging between health and housing sectors for this collaboration to really like blossom. So would love to see that happen. Jean put in the chat, PHPDA is exploring potential housing on our campus with help of Department of Commerce. Could you speak to Mary's Place substance use and/or harm reduction model? Oh, I'm guessing that's for Alyson.
Sure. Yeah, thanks for the question, Jean. I think this is an area of continual growth for us. So in regards to, it looks a little different depending on which program we're talking about. So in regards to our outreach work, we're zero barrier, and we lean in hard to harm reduction. We're working with families who are already living unsheltered, and we're supporting them with their unique needs to help navigate to housing. And so, we want to support them in like reducing harm in any way possible. Addressing their substance use in the way that they are ready and with whatever works for them. So for our outreach, we're very flexible, and again, lean in really hard to harm reduction and just supporting people in the way that they define they need at the time that we're working with them. For our shelters, it's a little bit different because we have communities where people are living with other people's kids. And so we've really been working to understand, what does harm reduction look like when we're talking about families with children. So we've been undertaking a journey for the past number of, really the past decade, to really understand what are best practices related to harm reduction when it comes to families with children. And there's just not a lot of learning in that field that exists, and not a lot of guidance. And so we really have been approaching substance use, harm reduction on an individual basis by household. Within our shelters, we have more of a behavior-based kind of agreement with people. So we do ask that our guests when they're in shared space, be awake and alert and be able to actively parent their own children, because we don't have the ability to provide care for people's kids or make decisions on behalf of people's children. So that's really where we live with our substance use and harm reduction work in terms of shelter. We also, again, work to get people connected when they're ready for supports. If someone has, if they are using substances and they'd like to get support to consider a different path for themselves, then we work to get them connected to some external agencies that provide that explicit support. And then I see your follow-up question around when I say children. We serve families with kids, and the way we define kids is birth to 18. So we have really young people that we're serving across the developmental kind of gamut from birth to adulthood.
Awesome. And I'm seeing Colin Maloney is sharing, hey Colin, is sharing a few resources from the Healthcare Authority about some housing and healthcare work that they are doing. So those links are in the chat if you want to check those out. And to wrap us up here, of course, if you continue to have questions, please put them in the chat. You can also email myself, or I'm guessing Alyson, you put your email in the chat as well. Please feel free to reach out with questions or information follow-up. But to close this out here, I would love to just have a little intro question. So going back to Mentee, let me share my screen again. How can you support this work in what you do? Curious just to hear about, you know, what's on your mind, what's resonating with you really, and how might you be able to use any of this information in the work that you're currently doing, whether it's integrated health and housing work or not. We've got curiosity about specific needs and research in Clark County. Engage in collaborative cross-sector conversations, building awareness, support coordination / build capacity to leverage funding across systems. Rural versus urban counties, how to make sure everyone gets the support they need wherever they are. Fundraising that supports health work. Policy implementation, outreach, coordination, finding service gaps, and how I can bridge those. Create opportunities for family to share about their needs with decision makers. Funding and long-term sustainability. Already doing work discussed, awesome. Need better communication means to access homelessness providers in all sectors. Just give y'all a minute if there's any other things on your mind. Our team of care managers help Medicaid members challenged with housing stability and work with multiple housing providers to gain safe housing. This presentation has been helpful for my team. I'm glad to hear that. Fund emergency shelters, so we have the capacity / ability to offer health services too. Continue to look for ways to bridge healthcare and housing. Amazing. Well, we've come to the end of this presentation, not of this work, but I really want to thank everyone for showing up today and coming through. Alyson, for sharing your expertise. Shout out to fellow practice innovation team members who helped me on the back end. So thank you, appreciate it. And we are recording this webinar, so I would love to send it out to registrants after the fact. And I will also include source information. I realized too late that I should probably have a works cited slide. So I will get you any resources that I referenced when talking about data and things like that. So I will get that to you. And again, if you have any lasting questions, please feel free to reach out. My information's right here on the slide. And yeah, looking forward to what comes next for everyone.